Good morning. My name is Liz Levine. I am the Director of Development in the Sibley Foundation. I emailed with a lot of you RSVPing for this call. I want to thank you all so much for joining us this Saturday morning for this talk about pancreatic cancer. We are really excited to have you. And I also want to thank the presenters for sharing their time with us this morning. First, I want to mention a few logistics. This talk will be recorded. So we will send it around to folks after the call. But as you can see, everybody, all the participants are muted and anonymous. So the speakers, so you can enter your questions in the Q&A tab below as the call goes, and the presenters will respond after their presentation. So feel free to add those in. You can also mark them as anonymous if you'd like. If you'd prefer to do that. You all should have my email address from RSVPing, and it will be listed on one of the slides at the end of the presentation. But if you have any questions about anything, please feel free to reach out and I can try and get answers for you. So now, without further ado, I'm really pleased to introduce our moderator for today, someone who many of you probably know well. Dr. Val Lee is a GI medical oncologist who came to Johns Hopkins for her fellowship 8 years ago, and she loved the staff and patients, so she stayed on as faculty to develop the GI medical oncology program here at Sibley. Dr. Lee's research interests are in combination therapies to enhance outcomes for patients with pancreatic cancer, and her passion is for patient care, which I believe because I've spoken with many of her grateful patients, and I know we're really lucky to have her on our team. So with that, Dr. Lee, I'll hand it over to you.
All right, thanks so much, Liz. Thanks for coordinating all of this. And thank you to everybody for joining us. I know everybody's incredibly busy, so appreciate everybody taking the time. I guess, so what I'm gonna be doing as a moderator, we'll run through the set of events as we're going through this morning. We do have some slides and we'll go over a little bit more logistics as well as what we're hoping to come out of this. Hope you'll take away from this in the end. Dr. Bishbein, do you mind just sharing your slide deck so that we can just, perfect. Okay, all right. Okay. All right, so as you know, today's talk, we're going to be focusing on living with a pancreatic cancer diagnosis. And we're hoping that after today, we'll be able to give you some more information about our evolving understanding of managing pancreatic cancer and then methods for adjusting to such an intensive diagnosis. So for the next slide, we're going to jump to, we have 2 talks today. So one given by Dr. Michael Pishbayan and the second one by Samantha Rockler. We're dealing with a little bit of technical difficulties, so Sam will hopefully be brought over into the co-hosting part. But Dr. Pishbayan will speak for about 20 minutes regarding updates in the treatment for pancreatic cancer. After that, we will have a Q&A. So if you do have questions, you'll notice the chat box is disabled, so use the Q&A feature. If you would like to remain anonymous, there is a selection for anonymous on there. But please submit questions through there so that we can go and hopefully have a lively discussion. After his talk, Samantha will present her talk regarding about coping with the diagnosis. She'll speak for about 15 minutes, and then we'll again transition to another Q&A regarding that aspect of care. After that, we're going to wrap up the session and talk about ways that we can all be involved in pancreatic cancer, in the pancreatic cancer community. And this talk, as Liz mentioned, will be recorded. So in case something flew by and you really want to go back and peruse at your own leisure, Liz will be sending out that link. So Mike, if you don't mind, the next slide. And I'm going to touch more about this at the very end, but as we mentioned, that we know that most people attending today's talk have been touched by pancreas cancer in some way. And while today's webinar will be anonymous for all of you, we hope to hold more events in the future and perhaps facilitate creating a bigger community and support. And in particular, we want to put in a little bit of a plug for the DC PanCan walk. I think a lot of you know about the PanCan organization. We have a Johns Hopkins team, and that there's a walk on April 30th, leaving from Freedom Plaza at 8 a.m. for anybody who might join. I'll go over all those details again at the end, and Liz will send out more information, and she's a great resource for everybody. Okay, but without further ado, I wanted to get us over to talking for Dr. Pishbayan's talk. And for Dr. Michael Pishbayan who many of you know, is a great GI medical oncologist that we were lucky enough to bring over to Hopkins about 2 years ago. In his prior life, he developed the pancreas and GI programs, as well as the developmental therapeutics, so a lot of these early phase trials at both Georgetown and MD Anderson. He is the director here of our GI developmental therapeutics and clinical research programs. And his primary research focus, which he's going to speak to today, is a huge area of interest in pancreatic cancer, specifically in precision medicine, the idea of personalizing therapy based upon specifics of your tumors. I'll let him take it away from here. But again, please submit questions through the Q&A if you have.
There you go. Sorry. Good morning, everyone. It's good to see you all. I'm sure many of you are familiar faces. I wish I could see your faces. And I'm really excited to be able to do this. Actually, this is 2 years overdue. COVID put us behind, but it's critical for me to be able to play a role in engaging our pancreatic cancer community. With Hopkins, actually, it's one of the larger pancreatic cancer communities. And I think that there's a real relationship that occurs between physicians, patients, social work, nutritionists, and actually the rest of the team, the surgeons, the gastroenterologists, and everybody else. And I want us to think of us as a team in fighting pancreatic cancer and trying to do the best we can. So my job right now is to give you a quick update on sort of the medical facts behind pancreatic cancer, and then we'll take some questions at the end. I've got a fair number of slides, so I'm going to go quickly, but as Val said, we're going to record this so you can go back and look at it at your leisure. So these are my brief disclosures. So pancreatic cancer is unfortunately a disease that's not uncommon. And when we talk about pancreatic cancer, most of us are referring to pancreatic ductal adenocarcinoma, or PDAC. Now, that accounts for about 90% of all pancreatic cancers. There are some patients, about 5%, who have pancreatic neuroendocrine tumors. Those carry a whole different prognosis, a whole different treatment plan. And then there are even some rare types of pancreatic cancer. But today we're really going to be talking about the typical pancreatic ductal adenocarcinomas. Who gets pancreatic cancer? Well, we really don't fully understand. There's probably about 7 to 10% of patients who have an inherited genetic syndrome that you see the genes listed here. We're going to talk a lot more about those. But really 90% of patients, we don't know why they're struck with this disease. There are some possible modifiable factors such as smoking and obesity, but in all honesty, these aren't slam dunk risk factors the way, for example, smoking is with lung cancer. Usually it's just unfortunately being struck with bad luck. What we do know is that pancreas cancer actually, again, is not an uncommon disease. There's more than 60,000 patients that were diagnosed in 2021. It's actually growing in incidence, one of the few cancer types that is increasing in numbers in the United States and across the world. And actually, it's expected to be the second leading cause of cancer-related death in the United States by 2030. And that's typically because it's diagnosed at a later stage, which we're also going to talk more about as well. So most pancreas cancer, unfortunately, is still not curable. Now, we're really trying to change that paradigm. But at this day and age, it's because most patients who are diagnosed, they're diagnosed with cancer that has already spread. And we really still don't know how to cure patients whose cancer has spread. We do know how to treat it, and treatment has definitely been proven to help, and I'm going to go over that. But of the patients who have localized disease, roughly about 20% will be rendered operable or are operable from the outset. And unfortunately, many of those patients, their cancer still does come back, usually within a year or two. So our true cure rate for pancreas cancer is only about 10%. That is progress. I know it doesn't seem like much progress, but that is progress, because even just a few years ago, it was down in the single digits, and about 15 years ago, it was about 1 or 2%. So we have made some gains. Why is the prognosis so poor? Typically, it's diagnosed at a later stage, like I mentioned, and more than half the patients are diagnosed at more advanced stages. And that's because the symptoms really aren't very apparent until the cancer has learned to grow or spread. Some of it is because we don't have really good screening or diagnostic tools. We can't tell you, Dr. Lee and I, the number of patients that we've seen who've had tests done, who've had CAT scans done, and MRIs, and that actually may have missed the cancer that was there early on. And we don't have any good screening tools. CA 19-9s and CEAs that we check regularly for our diagnosed patients are not screening tests to look for these cancers. There are also very subtle symptoms that develop: abdominal pain, weight loss, discomfort in eating. These are really vague symptoms. And even diabetes, which has some association, there's 30 million diabetics in the United States. There's not 30 million pancreas cancer patients. So these things can be very confounded. But the good news is that we have improved survival. And this is a slide that I hope to continue on into the future. It's now at about 2018, but we really are making progress, where the median survival for patients with more advanced disease was less than 6 months 20 years ago. But now we steadily are seeing patients with advanced disease who are living a year, year and a half, and in some cases actually a survival that's even defined in years, not months. These are a couple of medical slides that I'll go through, but I'm happy to walk you through them just so it's clear. This is really just to highlight and illustrate the fact that we are making progress in pancreatic cancer. We have two cocktails. In some ways, treating pancreatic cancer is somewhat limited, but somewhat clear in what we're supposed to do. And our two cocktails that we use are FOLFIRINOX and gemcitabine nab-paclitaxel. Many of you have been exposed to this or are familiar with these cocktails. And these two cocktails were developed about 10, now 12 years ago. And they both were shown to be better than the previous standard of care, which was just gemcitabine by itself. And in a large trial, FOLFIRINOX had a longer survival than gemcitabine. And similarly, a couple of years later, gemcitabine and nab-paclitaxel had a longer survival than gemcitabine. Just to be clear, nab-paclitaxel's other name is Abraxane. So many of you may be familiar with the word Abraxane, but just to try and stay away from trade names, we go with nab-paclitaxel. There is also a standard approved second-line treatment for patients who've previously been treated with gemcitabine and nab-paclitaxel, and it's 5-FU, the pump that many of you all know, and a drug called Naliri, or nanoliposomal irinotecan. The trade name for that is Onivyde. So some of you may be familiar with Onivyde. And there's a generic form of Onivyde that's not encapsulated, that's just called irinotecan. And the combination of 5-FU and irinotecan, or Naliri, also was proven to help people live longer than the previous standard of care of just 5-FU alone. So with these two regimens, with these two cocktails in our back pocket, we actually have a sequencing plan now for the way that we treat patients. We either start them on nab-paclitaxel and gemcitabine or on FOLFIRINOX. There's no clear difference between the two in terms of survival. So we're perfectly comfortable starting with one or the other. We have different reasons why we might start with one versus the other. And then once the cancer grows, we want to keep in mind that we want to make sure that the patient gets the next line of therapy and the next line of therapy. So after nab-paclitaxel, it might be 5-FU and Naliri. After FOLFIRINOX, it might be gemcitabine and nab-paclitaxel. And then we do have third line options as well, or this is the space that we often will look to putting patients on clinical trials to try and continue to push that envelope. Now, these lessons that we've learned in more advanced cancers, we're starting to apply to more localized cancers so that hopefully we can improve the cure rate. So for example, the previous standard post-surgery was just gemcitabine by itself, but for now a few years, we are starting to use FOLFIRINOX in the post-surgery setting, and it has significantly improved the cure rate when we use FOLFIRINOX. So some of you may have been exposed to FOLFIRINOX after surgery, and this is the data that supports that. And we're starting to apply that in the preoperative setting as well, where we're giving FOLFIRINOX or sometimes gem nab-paclitaxel in the preoperative setting, and we think that we're doing a better job increasing the cure rate in that setting too. There are some really critical ongoing studies to prove that definitively, but some of the early evidence suggests that may be true. Overall, we do see that we're getting better than even 10 years ago. For example, there were a couple of large studies that were done in the late 2010s, and I showed you survival times that were shorter than this earlier, but now we're actually seeing survival times that are pretty routinely getting to be between a year and a year and a half. And so we think that we are continuing to push that envelope. Some of that is just making sure that we expose patients to that sequence of therapies. If a patient just gets FOLFIRINOX and never gets anything else, they won't do as well as a patient who gets FOLFIRINOX and then gets gem nab-paclitaxel and then gets a clinical trial. And it doesn't really matter the order that those are given. And we just need to make sure that all patients are hopefully being exposed to all treatments during their pancreatic cancer lifetime. And again, this is advanced cancer patients, I should emphasize that. But we know that these two trials that I mentioned, without getting into the details, they were actually negative trials. The experimental therapy in these two trials didn't improve the outcomes for patients. And so why were these negative trials? What can we do to improve outcomes? And one of the things that Dr. Lee mentioned was, can we be better at selecting who gets what therapy? And a lot of this is based on different biomarkers. So when we use our standard of care therapies, we use empiric therapy. And we're taught this in medical school. It's absolutely the right thing to do, where we do prospective randomized trials that we hope will benefit one group of patients. But progress that way is slow. And in pancreatic cancer, our threshold for success is actually relatively low. We get excited if we have a 30% response rate, meaning 30% of patients, their tumors actually shrank, or we improve survival by 3 months. But the reality is, when we do that, we're treating 10 patients to actually only benefit 3. All 10 patients will get the same treatment, and we usually don't know which 3 will benefit from the therapy. And the promise of personalized or precision medicine is, can we use these predictive biomarkers to identify which patients will benefit from specific therapies? Now, we know that germline testing, meaning the genes that a patient was born with, is recommended for any patient with pancreatic cancer. And Dr. Lee and I really try and be mindful to cancer. And some of the genes that we're looking at, I'm sure you've heard us talk about in clinic, include BRCA1 or BRCA1 and 2, and then a whole number of other genes as well. And about 10% of patients, again, 7 to 10% of patients, the importance of testing for this is identifying for the patient, because there may be therapy options, and also doing what we call cascade testing, looking at other family members, because there are potential screening tools to utilize as well. So one important thing is that we don't always identify patients who have a mutation that they were born with just by looking at their family history. Many patients will tell me, I don't have pancreatic cancer in my family. Well, the reality is that in and of itself doesn't mean there's not a mutation underlying there. And actually, about 40 to 50% of patients who we know have a germline or mutation that they were born with in the BRCA gene, they actually have no discernible family history at all. So again, emphasizing the need to test every patient. And we try and be good about doing that. If we've forgotten, please don't hesitate to remind us. Now, we talk about germline or tumor or mutations that a patient was born with, but then there's the mutations in the tumor itself. Tumors become haywire. This is true for every cancer. There's a lot of genetic alterations that occur in tumors, and some of these genetic alterations can actually lead to specific therapies. And in pancreatic cancer, that's no exception. We're really starting to see that about 25%, and maybe even a growing number of patients with pancreatic cancer have these molecular alterations or molecular biomarkers that exist in the cancer itself that actually may be what we call actionable, where there are specific therapies that link to the molecular biomarkers. So likewise, we should be testing for these molecular biomarkers in the tumor as well. And again, please don't hesitate to remind us or ask us about it. I've listed some of the subgroups here. Again, you're welcome to look at them further in detail. But similarly, the guidelines suggest that every patient, at least those with advanced disease, which unfortunately represents the majority of pancreas cancer patients, we should be testing their tumors as well to see if there is an actionable biomarker so that we can identify different therapies. And these therapies are impacting survival times for patients. I walked you through the sequencing of therapy, where a patient who gets a first standard of care treatment and then a second standard of care treatment, we are improving that survival time to a year or even up to a year and a half. But there's roughly 5 to 10% of patients who have these biomarker specific groups for whom we find specific therapies. And we are thankfully starting to see some of these patients live in timeframes that are measured in years, 2, 3, 4 years. And we really want to expand those groups and look for new clinical trials or new therapies that may be a benefit for those patients. So a couple of examples to highlight. This actually is Young Lee. She's one of our colleagues up in Baltimore. She really has become world famous for this work, to her credit, where she identified that patients who have what we call MSI high, or the other term we use is mismatch repair deficient pancreatic cancer, that they benefit from immunotherapy. Most pancreatic cancer patients don't respond to immunotherapy, but this roughly less than 1% of pancreatic cancer patients who do have MSI high cancer, their cancers respond nicely to immunotherapy. And when you look at these kinds of curves, what we're looking at is the growth of the tumor for each individual patient. And you can see that most of these patients, their cancers actually responded, meaning their cancers got smaller with the immunotherapy. And the arrows point to the pancreatic cancer patients specifically. This is all cancer patients with MSI high cancers. And the arrows are pancreatic cancer patients specifically. So we definitely try and look for this MSI high. Actually, we do it in every patient with advanced cancer for these reasons. Similarly, there are a group of drugs called TRK inhibitors, TRK, and the genetic alteration that we're looking for in those tumors are NTRK fusions. And patients with NTRK fusion, whose tumors have NTRK fusions, also respond very, very well with a class of drugs called TRK inhibitors. And this is, again, a plot that shows how many of these patients' tumors shrink. When it gets down to this level, these are complete responses, meaning the cancer disappeared completely. So we should be looking for this as well. And then, as Dr. Lee mentioned, I have a specific interest in patients who have BRCA1, 2 mutated pancreatic cancer, and we do have a class of drugs targeted towards that as well, where patients with BRCA1 or 2 mutated pancreatic cancers have a drug that can help, a drug called olaparib, and then it's probably not drug specific, it's probably class specific. There are other PARP inhibitors that also work for this disease. And patients who have germline BRCA1 or BRCA2 mutated pancreatic cancer, they do benefit in terms of control of their disease with this drug olaparib, compared to at least placebo. And so this is a class of drugs that we're continuing to try and expand and improve upon for the treatment of pancreatic cancer. Now, unfortunately, as promising as that was in pancreatic cancer with BRCA1 mutated tumors, not all patients will respond. So we get excited about these classes of drugs, but as you saw in those graphs that I was showing you earlier, not every patient's cancers will shrink down. And in the case of BRCA1 and 2 mutated tumors specifically, we know that about a third of the patients have a very robust response. A third of the patients, their cancer will respond for a while, but then actually start to grow. And a third of the patients are just completely resistant to the therapy. And we just don't know why to this day. There are some mechanisms that we're starting to understand, but there's really a lot that we don't understand. And so one of my goals, one of our goals at Hopkins in general, is to try and expand upon and build a research program focused on understanding what really determines sensitivity and resistance to therapy, so that we can actually further refine who should get what therapy, whether it's whether with olaparib or any of the other targeted therapy drugs. So one of the things that we're trying to do at Sibley specifically, at Hopkins in general, is to build a patient-derived model of cancer repository. We have grant funding efforts. We're also trying to gather philanthropy efforts to try and make sure that we collect every patient's tumor sample. And there is the ability to take those tumor samples, grow them in the lab. Of course, they're anonymized. Nobody's going to track you down with these tumor samples, but to grow them in the lab and to do testing on it and understand how these patients' tumors respond to different treatments. And this is really an image of it here, where we can use these, what we call ex vivo, outside of the body models, to try and look at different mechanisms of sensitivity and resistance to the different therapies. So I know I went through that very quickly. Again, feel free to ask questions or look over the slides again. But to go in general, pancreatic cancer is soon to be the second leading cause of cancer-related death in the United States. So it's a disease that we're all very passionate about. We really want to do everything we can to help treat patients. Chemotherapy has improved survival and does improve the quality of life for patients with advanced disease. So we try and coach you through and coax you into getting chemotherapy. Still in this country, 50%, more than 50% of patients with pancreatic cancer don't get any treatment at all, which is really heartbreaking. We should be treating these patients with the best treatments that we have available to us. And these actionable mutations that I mentioned, they're not rare in pancreatic cancer, and we should be testing every patient for their germline or inherited mutations, and we should also be testing most of the patient's tumors as well. And there may be the subgroup of patients with BRCA1 and 2 mutations and similar that actually may lead to cascade testing, family member testing, that may actually help us to screen patients and prevent the cancers altogether. So with that, I'd be happy to take any questions right now.
Wonderful. Thanks so much for Dr. Fishbein. I see a couple of questions already coming up in the Q&A. Please feel free to go and submit questions via there. Maybe we'll go for one of the first questions, which looks at, so to better understand what treatments may be of benefit in looking at these actionable mutations, do we have to have a surgical specimen or can we just use a biopsy?
Great question. We can actually use a biopsy. We just need enough tissue for the labs to be able to convert that to DNA, and it's DNA that's tested. And actually, even more recently, we're starting to use RNA as well. So different components of the cells. We can do it on a biopsy, and there are tests that are even being developed just doing it from a blood sample. The tests for the blood samples aren't as good as the tissue samples, so we do prefer tissue. But in cases where we just absolutely can't get access to a tissue, we sometimes use blood tests.
All right. And then more people are also asking, when should we be asking about doing the molecular testing? Initially at diagnosis, or should we be further down the road?
I think personally that testing should be started right away. Now, most patients with pancreatic cancer, when they walk in the door with their initial diagnosis, they're usually pretty symptomatic of their cancer. Pain, loss of appetite, loss of weight, loss of energy, even sometimes taste changes before they even start any chemotherapy. So we want to get treatment started right away. And chemotherapy usually helps people feel better, at least for a while. So despite the side effects, they usually ultimately feel better. So I don't wait for the test results to start treatment, but I definitely try and remember to do the treatment right away. And we have Caitlin and Dr. Lee and others reminding us to do the testing. We keep a list of who we haven't tested yet because we know that we need to.
All right, we've got a lot of good questions still coming on in. So I think there's a nice couple of questions that are really looking at sort of what the types of treatments that we should be thinking about. So in particular, what about the role of radiation, especially on people who have, say, an operable tumor? Why aren't we doing radiation instead of just chemotherapy that we as medical oncologists are talking a lot about?
Yeah, radiation is an effective therapy, and in certain cancers is part of the curative therapy. For reasons that we don't fully understand, radiation in pancreas cancer has just not yet been proven to help people live longer or help increase the cure rate. We do use radiation fairly regularly because there are other reasons to use it, including pain control. And in some cases, it does improve the ability to have a more successful operation. But at a large center like Hopkins and many of our collaborative centers around the country, we will do what we call a tumor board discussion. And it's a case-by-case discussion deciding whether or not we should be incorporating radiation prior to surgery for a patient who's going to have surgery.
All right, perfect. And I think the second part of that question, which I can also help answer, is, why would we even bother doing surgery if we can just do radiation? And I think it's always a hard thing, right? Of course, radiation, we think that people will recover faster, but ideally, if we can have a tumor removed from the body, that's going to be much more effective at hopefully getting to a cure as compared to radiation, where, as Dr. Fishbein was mentioning, we can't treat the tumor 100% effectively. So while you can recover faster, our hope is, especially in people who are very healthy, to get you through one big surgery, but to cure the cancer down the road. All right, I think another question about chemo, and a great question just about what we call adjuvant therapy or post-surgery chemotherapy. What kinds of treatments do we do? Dr. Fishbein, would you like to answer
Sure.
that?
So the chemotherapy that we use is IV chemotherapy still. There are some patients for whom we choose reduced chemotherapy, but we know that actually the proven benefit is with the IV chemotherapy cocktails. There is one cocktail that I didn't mention just for lack of time, where we actually do a combination of IV and pills, but the other combination, the FOLFIRINOX, is strictly IV.
All right. And then how effective as a screening device is the 3D CT scan versus MRI? This is a question we get a lot of the time. So yeah, maybe Dr. P can talk about that.
So it's not effective as a screening device.
Yeah.
So 3D scans, So Johns Hopkins actually had a large registry of BRCA mutated pancreatic cancers, not cancer, sorry, BRCA mutated carriers who were at risk of developing pancreatic cancer, and they followed them for 20 years. And for the first parts of the cohort, they actually were doing CAT scans on a regular basis, and they did not actually find the cancers any earlier. They didn't cure the patients more often. Now, for the last 10 years, both Hopkins and Mayo have published on using MRIs and endoscopic ultrasounds on an alternating basis. And there is some promise in that, where we're finding these cancers earlier. And actually a really important publication that came out a couple of years ago from Hopkins was that the cure rate, I told you the cure rate earlier, I won't go over those numbers again, but the cure rate for patients who had been screened and they found their cancers earlier was over 80%. So for those family members who have cascade testing, who happen to be BRCA1 or 2 carriers, we may be able to prevent their, or at least early, have a higher chance of curing any pancreatic cancer that may develop. And that doesn't even touch upon things like breast cancer and ovarian cancer for those mutations.
Yeah, and I was going to say that leads to one of these other questions that we see in the chat, but if I've been affected, is there a general screening that we should be asking about for our family members as well?
Definitely, definitely. The endoscopic ultrasound alternating with MRI is really the standard screening, but it's the guidelines are just very much in development. We're lucky that up in Baltimore, we have one of the world leading programs in screening patients who have at risk. So I think going up there, once a year would be well worth it. We also have doctors here that can help in the screening process as well. So I definitely would recommend that family members be tested and that we get them plugged into screening programs.
And I'll just give a plug also that there is, if you email pancreas@jhmi.edu, that reflects what we call the Hopkins Pancreatic Cancer Family Registry, which a number of people have gotten surgeries elsewhere, or else most major institutions do have a family registry, and it's in hopes that we can develop and help make sure that people get that information as we need this. Okay, and then here's another two-part question, which I think. What kind of funding has been allocated for research for pancreatic cancer? And is there anything that patients and families can do to stimulate more funding if it's needed?
So Dr. Lee will definitely go into this in more detail as we get towards the end, but the funding for pancreatic cancer is woefully inadequate. Actually, the Pancreatic Cancer Action Network has been lobbying Congress for years to try and make pancreas cancer get equal funding. And there was a bill a few years ago that passed that put pancreas cancer into the rare cancer group to increase the funding. But as I mentioned, it's not a rare cancer. And so we really need to do much more to build up the funding allocation. And that funding actually does help fund specific projects that will actually potentially be impactful. Much of the many of the trials that I showed you today actually were funded by initial philanthropic dollars. Dr. Lee's study on MSI-high pancreatic cancers, or MSI cancers in general, that was actually all institutional and philanthropic funding that really led to a worldwide practice-changing paradigm. And so I think, helping to raise money, donating to support our research programs has the great potential to make major impact.
Yeah, and I am going to say, as I said, we'll talk more about this at the very end as well. But I think there's a number of major organizations. Hopkins is very robust at doing research, and Liz Levine, who helped to coordinate this, will be a good contact in case you have any questions. But we think certainly getting the word out, making sure that making sure that other people are aware of it. So Pancreatic Cancer Awareness Month is in November, but making sure that people are thinking about this and that we can build this up. We certainly wish for more as much family and patient advocacy as possible. And Liz can also help you sort of direct what options might be here even at Hopkins. All right, and I'm being mindful of time because I want to make sure Samantha has time to speak, but actually it's perfect. One of the next questions is, which I think will segue a bit into Samantha's talk as well, but will be, can we talk about how patients can manage side effects more easily, which I think of as sort of a more side effects is not just chemotherapy side effects or treatment side effects, but also thinking about sort of the whole diagnosis overall. And I might sort of jump in for this one and just say that I think there's a number of different side effects, and each one should be addressed very specifically. And I think having a team that you feel comfortable with, Dr. Pishvan, myself, we try to create a good team to go and provide support for you, but we can't manage all of the symptoms. And so we oftentimes do invite the teams such as palliative care, nutrition, our wonderful social workers, and our navigators, and that you should make sure that you're aware of all of the different resources that we have available to go and help you through this, because side effects can include, the immediate nausea and vomiting, fatigue. So from a medical standpoint, we've got lots of medications that can help this, but there's also other things that we can think about to go and help support you through that process. But communication is key. We can only help if we know that symptoms are going on. And so just feel free to reach out to us whenever you need that. Okay. All right. Just in the sake of time, if we can, we'll tend to move over to this question over here. The next talk with Samantha Rockler. So I'll introduce her as well. I think as many of you know her as well, she's our phenomenal medical oncology social worker. While she wears many hats in the 3 years since she's joined us, she specifically provides care for our patients who have been diagnosed with GI malignancies, and she's going to runs also our patient pancreatic cancer patient support group. As many of you know, cancer can be so impactful beyond just the physical aspects of care, but also with the social and emotional health of both the person affected by the diagnosis and of loved ones. And so when I think about social work, I really think about two major roles that they play. They're not the only ones, but two major roles, but including sort of the very practical matters such as paperwork and thinking about transportation and how one takes leave, but also about the social, emotional aspect in terms of providing support and counseling in the time of difficult transitions and how to go and manage this diagnosis. And Samantha's going to speak next about coping with the diagnosis, and I hope that will be helpful. And we'll answer questions again after her talk as well.
Thanks, Dr. Lee. Thanks for having me here today. Am I in control of advancing these slides, or is that you, Mike?
I'm happy to do it for you.
Awesome. Would you mind going to the next one?
And Mike, I think you're on the full screen as opposed to sharing both of them as opposed to just the single slide.
So as Dr. Lee said, I'm Samantha Rockler. I'm the GI oncology social worker. I'm so privileged to work closely with Dr. Lee and Dr. Pishvan and the rest of the GI team, and also with so many of you who are here today, who I'm really lucky to know. And as Dr. Lee said, my focus is really two things. One is making sure that there's nothing getting in the way of you being able to actually get your treatment. Things like financial issues, medication costs, transportation issues don't disrupt your ability to get the treatment you need. Unfortunately, these barriers are really real for some people. And that's something that we're really fortunate to have funding from generous donations and the foundation to support, which does really differentiate us from other cancer centers and sometimes makes my job a lot easier. And also, by the way, that funding supports positions like mine, and I do not get billed to your insurance. It's just part of the support that we offer patients at Sibley. But the other part of my job is really helping you figure out how you're going to live well in the face of a really challenging diagnosis. So I'm going to talk pretty briefly about a few key coping strategies. But unfortunately, I'll tell you right away that, as you already know, there's really no easy answer. There's no easy way to do it. But in my experience, there are things that genuinely can help. So the first is really engaging your support system. People are often surprised by how many people in their lives want to help when something like this happens. Could be friends and family, could also be neighbors or members of a faith community that you don't even know very well, but people genuinely do want to help when these things happen. And what I hear often is that it isn't always easy to accept that kind of help. A lot of people may never have needed help from others before. And so that's something that I talk through with patients and with caregivers is kind of getting your head around accepting it. It also can be really overwhelming because you have a lot of people who are asking, how can I help? And sometimes it's a whole job in and of itself just to distribute tasks. So it's important to find someone who can kind of quarterback and manage all of that, who isn't you and who probably isn't your partner or caregiver, so that there's someone who can direct people if it's picking up a child from sports practice, if it's delivering groceries, doing a pharmacy run, sitting with you at chemo, those kinds of things that can really take something off of your plate and off of your partner's plate, and it makes a huge difference. My favorite thing to talk about is mindfulness and meditation. And sometimes I get sort of an eye roll when I start talking about this, but the thing is that it really does work. It really does help. It makes a difference in day-to-day coping. When you get a diagnosis like this, there's this very understandable impulse for your mind to kind of run away into the future. And that's actually adaptive, right? In some ways, to be thinking of all possible problems and kind of pre-solving them. But unfortunately, when it comes to living with cancer, that just makes life kind of hard and scary. It's not something you can really do effectively. A mindfulness practice can actually train your mind to stay present in the moment. And being able to really do that can reduce your anxiety and improve your ability to cope. Meditation is a great way to learn this skill. And I have a lot of people tell me that they don't like meditating or that they aren't good at it. And I always tell them, of course you aren't. It's a muscle you have to train just like any other muscle. No one's good at it the first time they do it, but it is really impactful the more that you can do it. Another thing that meditation helps with is something called reactivity, which is a very intense emotional reaction to something. This is like when it's Sunday night and you open your work email and you see something that upsets you, and all of a sudden your heart is pounding and you don't sleep well because you're just going over this upsetting thing in your head. That's reactivity. And I like to think of sort of building a reactivity bubble so that when you see that email, instead of having an emotional reaction, you can just think, okay, and you move on and you enjoy your night and you sleep well and you deal with the issue when you get to work the next day, which is the appropriate place to deal with a work issue. For a cancer example, let's say you have a scan coming up. Reactivity is part of what causes that scanxiety, which is totally normal, totally understandable, basically universal, I think, for cancer patients. And scanxiety can ruin entire weeks, right? If you can create a reactivity bubble for yourself, you may be able to notice the anxiety building, to take some deep breaths, to remind yourself that a scan doesn't cause something to happen, it just shows what's already there. And that no matter what the scan shows, you can stay present in the moment, you can address whatever comes up, you can deal with bad news and you can deal with good news. You can take a step back and focus on your breath. And you can also choose to deal with the scan in the company of your wonderful oncologist who will guide you to the next step. And that's the appropriate place to focus on a scan, with someone who can actually interpret it and offer you a plan. We offer free meditation groups multiple times a week over Zoom, also yoga and Reiki. So I would encourage you to be open-minded and try these things. Pam Getz, who I believe is here on this webinar today, is our wonderful program manager, and she does an amazing job at all of these programs, as anyone who's been to one can attest. We have really excellent meditation and yoga teachers, as well as Reiki masters. And again, all of this is available to you for free because we're so fortunate to have support from donors. There's also a lot of apps for meditation. Some of my favorites are Calm, Headspace, Insight Timer, and lots of free guided meditations online. And I'm happy to share some of my favorites with you, including some that are geared towards cancer patients and caregivers, if you're interested. My email address is on the next slide, so you can feel free to email me. Oh, sorry, can you go back though? Not quite ready for it. Another really important thing is being kind and compassionate with yourself. This is actually a skill you can sharpen through meditation, by the way. But that's reminding yourself that it's normal to be anxious, fearful, sad, angry, all of these feelings when you get a diagnosis like this. It's a grief process. It's a process of loss, lots of micro losses and also big losses. And it's normal to grieve yourself and your life pre-diagnosis. It's normal to grieve the plans you might have had that you have to change or adapt. Sometimes just the very act of allowing some room for these feelings helps to keep them kind of an appropriate size and shape, rather than having them crowd out everything. Because while you're having all of these heavy feelings, you also are experiencing joy and gratitude and love. All of that stuff can happen at the same time. And that's part of how you live well when you have a diagnosis like this. I was just the other day having a great conversation with someone who I think is probably here. And we talked about how you don't hand in your human card the moment you get diagnosed with cancer, even though sometimes it really feels like you do. There's a whole range of human emotion and experience that still belongs to you, that you still get to experience because you're a person, not just a patient or a caregiver. There's a really wonderful book written by a young woman with stage 4 cancer, and it's called "There's No Cure for Being Human," something like that. And I just think that's such a great way to put it. This is all part of being human. And that kind of leads me to my last point, which is seeking professional help when needed. Sometimes the feelings that I just talked about become unbearable or just too heavy to manage on your own. And that's when it's important to seek the help of a professional, which could be a therapist or a psychiatrist who specializes in cancer. Religious and spiritual leaders often also have really good things to say. A good place to start is talking with me, and you can connect to me either through email or by talking to Dr. Lee and Dr. Pishvayan. They will put you in touch with me. We can go to the next slide now. So my email address is right there. But I also just wanted to talk about our monthly support group for patients with pancreatic cancer, which I run. Our next meeting is on April 14th at noon on Zoom. And we would love to have you. So just email me and I'll get you on the mailing list. It's a space to talk to other people who've been there, who are there, and can relate to the small annoyances, the big existential issues. Nobody has all the answers, but it can really reduce the isolation that is pretty common to feel when you get diagnosed when you get a diagnosis like this. And it's also really meaningful to be able to reassure and connect with someone who's maybe more newly diagnosed. And that is something that you might not know, that you have something really important to say to someone who is behind you in all of this. So I hope you'll think about joining us. We have a lot of programs, like I mentioned earlier, the meditation, the yoga, the Reiki, caregiver support groups. So if you email me, I can also just send you a calendar with everything, and we can go from there. So that's all I've got. Feel free to email me, and I'm available for questions if there are any, but otherwise I will hand it back to Dr. Lee.
Okay, thank you so much, Sam. Really appreciate that, because as we said, I know that this is always such a, cancer doesn't just affect the body alone, but it affects, every other aspect of your life, as well as the lives of those around you. And I will say, I think, the pancreatic cancer support group, I've heard is wonderful, but the docs are not involved in it directly. So, which is always a really nice thing, actually, I think, so that there is a safe space away from us to be able to talk about things. Now, if we have questions, please feel to go and put them directly into the Q&A section as well. And I think there's something. So I think this is a great question that just came in, but what role do caregivers play in supporting the patient emotionally and getting treatment and understanding the plan? I think that's a really big question.
Yeah, I mean, I think that as a caregiver, you're often the closest person to the patient. And so you know them best, and that's, their emotional, what they're normally like, and can kind of see when they're starting to get depressed or anxious. You also know them physically well. And so that can be really helpful for the medical team, because sometimes there are things that might be red flags to you that others don't notice as quickly, because you just know them the best. And so I think being able to just be there and being in communication with the care team, also really helpful to be the one maybe taking notes or writing down questions. A lot of times it's really helpful to kind of come into your appointments with a list of questions, and that way, you won't miss anything, you won't forget anything. Also being able to be connected to the MyChart account in case you need to send a message to someone on the care team, or keep track of when the appointments are, things like that. But with all that being said, being a caregiver is a huge responsibility. And so also important to, in addition to all of that, try to figure out how you can take good care of yourself and engage with resources for support as needed as well.
Can I comment on the caregiver and the support family support network? I think that pancreatic cancer patients, and actually any cancer patients, have a much larger support network than perhaps they realize. And many of us are hesitant to ask for help for a variety of issues and reasons. But I think when you do break down that barrier and you ask, that people generally are willing to sort of bend over backwards to help out. And I've seen that in some of the villages of support for some of the patients actually on this call, where just people will come out of the woodwork. And if one person helps, once a month, but you have a network of 10, 15, 20 people, then actually you're getting support almost every day. I also just wanted to mention that obviously the COVID period was very hard for all of us for a variety of reasons, but especially not being able to have that caregiver in the room with you. And hopefully, knock on wood, if we're getting out of this era, then having somebody in the room with you at every visit is going to make a big impact as well, as Samantha was suggesting.
And I might also say, that being a caregiver, being a patient is incredibly hard. Being a caregiver is also can be really difficult as well. Samantha, I'm not sure if we have any of our caregiver support series coming up, but I know in the past we've participated and had have had like sort of a couple hour meetings sort of talking about and what are the best ways to advocate for oneself or for one's loved one, but also preserving one's own mental health as well throughout this, because I think it's not uncommon that we see a lot of caregivers really have a lot of fatigue in their own medical issues, and we just want to make sure we're taking care of everybody, and we want to be respectful of that as well.
Our caregiver support group meets twice a month, actually, also on Zoom. So again, email me and I will get you the calendar, but a good resource to take advantage of if you can.
Okay. And then another question, are there financial assistance programs for pancreatic cancer patients and families? It's a great question.
Yeah, so it sort of depends. It depends on a lot of things, including the specific needs and demographics and things like that. But there certainly are different sources of financial assistance available at different times, sort of in cycles. But the best way to start to get connected is to just talk to me, and we'll kind of go over what's available and search the resources and all that for you.
Yeah, and I agree. I think it is very individual. I think, unfortunately, many of you all know, like, say, the cost of Creon, which is oftentimes, an incredible cost, and unfortunately not covered by a lot of insurance companies, but is necessary for a lot of people who have been diagnosed with pancreas cancer or undergone surgery. And there are resources to go and support. There are oftentimes there's financial restrictions as to how much you need to make, but that we can go and help explore those for you, or sort of think about. And that's a lot of, I think, when we sort of talk about building the community, that sometimes that can be helpful, because oftentimes we actually learn about little backdoor ways to go and get things, maybe from other patients as well. And that community can be really important. But certainly we know that cancer care is expensive for a lot of people, because it's not just, the chemo point and the CT scans that are paid for by your insurance, but it's the transportation, it's, taking time off from work. And those are things that you should bring up with us as a team so that we can go and help you through that. Okay. All right, there's just a couple more minutes. So if it's okay, we're going to move on to the last slide. But that, I should say again that all of us are available to you for questions as well. And then Mike, if you don't mind pulling up the last slide as well. As I really do appreciate all of you joining us today, and I hope it was really informative, and that, as I mentioned at the beginning, though, that part of it, we're hoping to be able to be part of a bigger community to support you, but also trying to learn more about pancreas cancer. And I think there's some ways that we can think about being involved. So in particular, I think Samantha mentioned the monthly pancreatic cancer support group, so built by our patients and Sam and run by, and I think that is a really wonderful group. And, if group is not right for you, you can talk with Samantha also about other resources, or if not, even at Hopkins. But there's a number of different places around the community and around the area that we can really think about. I think without research, we wouldn't be able to make advances. And while it can be intimidating, consider being part of a clinical trial if it's the right thing for you. So talk with me or Dr. Pishvayan or with your other team members and see if there might be good trial options for you to go and participate in. As I said, though, I did want to make a big plug for the Hopkins for the PanCan Purple Stride Walk. So this used to be in November pre-pandemic, which was always a very chilly time to be going for a walk. But they're doing the National PanCan Purple Stride Walk. So in all the cities around the country on April 30th. So DC, it's in person this year. It is an outside walk, 8 a.m. at Freedom Plaza. We would really love to see, Dr. P and I will be there. And if anybody else would like to join us, we'd really love you too. You could even join our team or donate to our team if you'd like, or I know that probably a lot of you already have your own teams as well. I do have listed in here how to get to the link. It's not the easiest way, but go to pancan.org. You can click register now for Purple Stride, and you can either sign up on your own, or if you don't, join our Johns Hopkins team. So just search for Johns Hopkins or the fundraising and teams. And Liz is going to send up a follow-up email that includes sort of this link to this, but also how to get to that team directly. The registration is free, and I think truly building a community helps you to connect to other people in the DC area who've been really been affected. And then if you are interested in contributing to both research or other programs at this cancer center, like Samantha and the patient and family caregivers programs, to support our work and help other patients, just reach out to Liz Levine. She's also a great person in general for resources, and she can direct you to where we might be able to get more information. So I think a lot of you have her email, but that's her phone number there as well. But thank you all so much for your time. I don't know if there's any other closing remarks from Dr. Pishvayan or Samantha, but really appreciate you joining us today.
I will add real quick that this is really a community that is near and dear to my heart, near and dear to Dr. Lee's heart. Not to take anything away from our other cancer patients, but pancreatic cancer patients are very special. And we really want to devote our time to an effort to treating this disease and to helping you all through your journey.
Okay. All right. And please feel free to email us, send us a message, or send a message through Liz. She knows how to get in touch with us very easily. We hope you are all having, we hope you all have a really wonderful Saturday, and that it's not too chilly outside, and get to spend some time not thinking about pancreas cancer also.